First of all, I welcome you today in the name of Department of Diagnostic and Interventional Radiology at University Hospital in Frankfurt to our live case transmission. I would like to introduce my colleague, Dr. Bodel, Boris Bodel, and I'm Tatiana Gruberu. And our case today is Transarterielle Chemoembolisation of HCC. This is a 54 years old patient with 3 liver lesions in liver segment 8, 8, 5, and 6. And together we begin a chemoembolization of HCC lesions. So we're beginning. We are going to pleasure of sidewinder catheter.
Could you comment whether or not this patient has been treated before, or whether this is the first treatment for this patient?
Yes. Sorry. This is the second CTase of the liver lesions. The first CTase the patient had in December last year. And the history, in the patient history, in medical history, the patient had liver cirrhosis because of hepatitis B, type 2 diabetes mellitus, and hypertension.
Unfortunately, we haven't seen any CT or MRI for the CCC. Could you just explain us, is this a hypervascularized CCC? How was the result of your first CTase? Was this a combination chemotherapy in your first CTase? What are we dealing with today in your intervention, please?
In the MRI, in the arterial phase of MRI from December 2017, we can see 3 liver lesions. Sorry, in liver segment 8, 8, 5, and 6. Mm-hmm. Oh.
Was the imaging that you were referring to in December after the initial therapy, or was it prior to the initial therapy?
That's for initial therapy.
For the initial therapy, did you perform a mono chemotherapy in conventional TACE? Because Frankfurt is very strong in the combination with 2 or 3 chemotherapeutic agents in CCC. Can you stress on that point, please?
The hemotherapeutic agents was mitomycin C, and embolization agent was lipiodol, and the technique was a sandwich technique.
We had been embolizing with mitomycin C in combination mixed with lipiodol, and as an temporary embolic agent we had been using Embocept S. That's our protocol for those patients with advanced liver cirrhosis.
With this Embocept for CCC in this very palliative situation, do you see a difference in the for the hypervascularization of the CCC? Are they doing better? Is this important to look for, or is it just go for the CCC? How is it? Is there a difference if they are very well hypervascularized?
We use that protocol especially if we have tumors with a high vascularization. If they are lower vascularized, so like combined tumors with CCC and HCC, we use a different protocol.
Das gibt's ja gar nicht. Ich bin wieder da.
Maybe Dr. Bodell, you can meanwhile explain us what material you are using.
So
You're
we
not
have
in
a
a-
sidewinder catheter 5F.
Yeah.
At this time we use it to place it in the celiac trunk. As you see, we have a special situation at this time because we have now no access to the celiac trunk, and we'll find it right now, I hope. So we used at first, after local anesthesia and the puncture of the vessel in the groin, an introducer. It was 5F introducer. After this first step, we place the sidewinder catheter, and after we have access to the celiac trunk and will perform an angiography, we will use a microcatheter.
So, I need contrast medium.
What type of microcatheter you have on the table, Dr. Bodell?
It's a pro-grade microcatheter 2.8F.
So,
And we have a connecting system to introduce this microcatheter through the sidewinder catheter if it is placed in a safe position. And we will have now a look to the situation.
okay, das reicht.
And Dr. Gruber will get contrast agent to Check. the location.
So, jetzt machen wir das mit Atemkommandos. Ja? So, einatmen, ausatmen, nicht mehr atmen, nicht bewegen.
Some pressing commands.
Breathe in, breathe out, and no breathing.
And will you now go for an overlay,
Okay.
or do you do a roadmap in the next step?
No, we will do a
A
DSA
roadmap.
subtraction.
Das ist ein DSA und das ist indirekt Portographie für in so. For detection of celiac trunk and indirect portography for pooling of contrast medium in the spleen with contrasting of portal vein, and in portal vein is in thrombosis.
Now Dr. Gruber places a guide wire through the sidewinder catheter to get access to the right hepatic artery.
artery. Let's finish. And we use a super microcatheter system.
You have the Y connector now, and then you use the pro-grade.
Yeah, yes.
Okay.
Yes.
Just out of curiosity, our site in the U.S. in New York, we've largely moved over to performing interventional oncology cases through radial access. for patient comfort and to facilitate these procedures being done more frequently as ambulatory therapy. I'm just curious in Europe whether there's been the introduction of radial access for these procedures yet, whether it's been met with enthusiasm or with conflict.
That's a very important question for the future. I think everyone who has used transradial access has a happy patient later on with a system occluding the puncture. But the big question, the big problem is, this is for ambulant therapy. And we don't have that for chemoembolization and stenting. So we can do that, and we have done that. I think most of our guys have done that. But it was introduced and developed for something else. So cost.
Maybe I can comment on this. We do about 70 or 60% of the chemoembolization is outpatients. We have an outpatient board. We did some radial cases, but if you repeat it with the radial access, and normally we go for 3-4 courses, I have seen, and the second point, I don't know why we have a high ratio of female patients. And you know, in the females, here in the radial, I have seen quite a lot of problems. Maybe it was my inexperience or whatever, but I mean the male heavy-weighted German patient is not a problem, but the females...
Are the problems ischemia or that the radial artery occludes and you're unable to re-access the patient?
And we made a questionnaire on about 25 cases we did, and so we had an option for the patient for the next time, whether he wanted to have again a radial or femoral. We all our patients, we have an occluding system also for the femoral access, and the patient were more in favor of the femoral access.
If we discuss transfemoral versus transradial, maybe it's not the point. I see it for Germany, the question it's transbrachial versus transradial for renal stenting and mesenteric stenting, because transbrachial has a higher complication rate. And with the new transradial systems, the complication rate is significantly lower. So I think we have to discuss that for renal and mesenteric, but not for TACE, because some TACE are 10 punctures over the next 3 years. And I don't know any patient with Sloan Kettering which had 10 TACEs in a row. So I think maybe for something else, very good indication.
So the microcatheter is in arteria hepatica dexter.
Okay, and now you go down to segment 6-5, huh?
Yes.
I'm not able to see any hypervascularized lesion. Do you use cone beam CT sometimes in patients like
Yes,
this?
the first time, yes, always for the first intervention. But now we have it for the second treatment, and you see nicely still that the lapidole is still there. So we have a good visualization. Also, there had been small satellites in segment 7.
So you rely on the combination of the MR showing hypervascularized lesions and the angio where you see the lapidole in place.
From the protocol, how many milliliter of Ambocept S are you using for this CCC in palliative setting?
Now, normally we go to 3 or 4 milliliter, which is about 200 milligram. Okay.
You are one of the only centers which having chemosaturation and these techniques for CCC, Professor Vogel. If I could choose, I would do chemosaturation. Am I wrong?
Yeah, or radioembolization.
No, I think we have a lot of more options. We have radioembolization, and I mean chemosaturation. We did a case on Monday. It's a 4 hours procedure. You need full anesthesia. And the patient will be 10 days on the wards, and then we look at the thrombocytes. But I think radioembolization is a big topic to go, and maybe holmium or whatever.
So for a case like this, how frequently do you treat the patient before you would repeat the imaging?
Normally we go for 3 procedures, an interval of 4 to 6 weeks.
Bitte.
Nochmal einatmen. So, jetzt bitte nochmal ganz normal atmen. Jetzt einatmen, ausatmen, nicht mehr atmen, nicht bewegen. Da müssen wir den
Question for your technique. With Embocept S, we're not frightened from necrosis, we're not frightened from many complications. Do we have be as super selective as with DAPTase, or can we just go for low bar, for example?
That's an important question with the particles which are temporary. You can go for subsegmental or lobar. No, and here in this patient, for example, our intention would be to perform 3 TASE procedures, and maybe then it's a candidate either for radioembolization with really a segmental ablation, you know, with a high concentrated, or we try to ablate it with microwave ablation, RFA, laser, or whatever. In US, how you would treat that patient?
We tend to choose radioembolization first before chemoembolization. It's not truly evidence-based. It's really a experiential decision. Anecdotally, we found that the effects of radioembolization, especially for primary HCC, is not as pronounced if the patient has undergone prior chemoembolization. So currently right now in 2018, our default strategy for newly referred primary hepatocellular carcinoma would be to undergo radioembolization. We are performing radiation segmentectomy, as you referred, and so if it's a single lesion, that is a protocol we're using more and more frequently, but chemoembolization is really reserved to patients that are not candidates for radioembolization or have previously undergone therapy with radioembolization.
I mean, Dr. Gruber, if you comment, now we are very selectively ahead in the vascular territory for this, the segment 6 lesion.
Segment 6?
Yeah.
Yes.
So what is your next step?
You can see the lipid. This application of mitomycin C and lipidol.
Now you mix mitomycin C with lipidol with a clock, or you?
No, we use the sandwich technique. No.
No, you do sandwich. Okay.
You are now very super selective. So why not now using very small particles? Because now the Embocept advantage to go for low bar or for 3 segments in one position, you cannot use that. So this is now so super selective. I would say go for tandem 40. We don't have data, I know.
Lipidol is now becoming also very expensive. Yeah. If I think on ablation, I like to have to see the lipidol, you know, that's maybe...
So we're all commenting on the fact that there's a lack of data that judges many things that we're doing. So, a lot of industries here, obviously, maybe we could comment on what the need is right now to, fund prospective studies to try and answer these questions so that we can benefit our patients. We were speaking on the previous case whether or not there's benefit for smaller particles versus larger particles. Do you think there's an opportunity here to have a prospective study looking at smaller particles versus larger particles for drug-eluting beads?
No,
Okay.
because we are working on these studies for 5 years, and the answer from the industry is very easy. What can we win? If we do that 40 against the larger, what could we win? If we do 1 against the other company, what could we win? This is the problem. You cannot do that over the industry. You can do that only over CIRSI, for example, to do a multi-institutional, multi-center with CIRSI behind. This is the only way to go. From the industry, they will not pay 1 to 3 million of euros for that, and to lose at the end.
Big European trial we did on comparing DC beads versus conventional TACE showed the problem is what maybe all the audience have seen, that chemoembolization is a little very individual, you know. Each institution has a little different concept, and to perform a study with the same concept over 10, 12 institutions, even in US, I think it's a problem.
The issues of individualization of the technique, humbly, I think we're all going to have to overcome. I think we're going to have to migrate to a more standardized approach in order to generate level 1 evidence to guide what we are doing. And we all obviously respect all of our colleagues and their skill sets and their experience, but I think this is a time when we're all going to need to band together to generate more prospective work.
Okay, but I think we are thankful to the Frankfurt team. They did an excellent job.